All righty. So many of the things that Dr. Bitts just talked about, the surgical theatre, actually are upstairs in Mighty. There's robots, basically they're being demoed here and up in Mighty if you really want to get your hands on and play with them. So next, we're running a little bit behind time, but we're going to go to the operating room, hopefully. This is always one of those tricky things in trying to get these things timed. So let's see if we can connect into the operating room so that they know that we're here. And then, so that's what we're going to take you to. Okay, we're going to give a little bit of an introduction to this before we actually get to that point. So I'm going to invite Dr. Ponraj Chinnadurai. He's the research scientist here with Siemens. And we're going to talk a little bit about what you're going to see, okay? I've got a prop. The prop is, this is a Heartmate 2 device. This is a pump. I should probably, Heartmate 3, I'm sorry. It won't get me fired for saying the wrong thing. And so maybe I should give it to Tom. He knows a lot more about this than I do. Bottom line is it's a pump that's going to be attached to the heart. They're taking one out, putting a new one in. And we're going to talk a little bit about the imaging and planning from this. So Ponraj, come on up here and we'll show some of your wonderful work. It's a little bit of takeoff on what Dr. Bitts was already talking about.
Thank you, Dr. Lumsden, for the opportunity. For the audience here, I'm pretty grateful for Dr. Lumsden for giving me this opportunity. And also, I would like to say hi to the students who are listening to us in the Mighty, in the 5th floor. So what I'm going to do in the next few slides is show pictures. No complex medical terminologies. Show pictures and tell the story of what we are trying to do from a non-medical standpoint. I'm a physician by background. I work on imaging-related topics. So one of the things that I have learned by working here in the field, working here at Houston Methodist, how do you communicate complex information from one specialty to the other specialty? If I have to point out one thing that I have learned is, how do you communicate imaging technologies or the information, the loads of information that we have in these complex imaging data sets to surgeons who are actually doing these procedures. So, and that's where I'm going to focus on. So what I'm going to show here is how we can see the structures in the CT images, how we can virtually implant the devices. I'll let the images speak for itself. So this is the Heartmate 2, which is the pump that the patient currently has, which we are going to exchange. So, and let me go back a second. Yeah. So this is the inflow cannula, which attaches to the LV, left ventricle. And this is the outflow cannula, which attaches to the ascending aorta to get the blood flows through the pump into the ascending aorta. So the reason we are kind of exchanging, why we are exchanging this pump is because since the blood is exposed to an external circuit, it got infected, and that's one of the reasons why we are exchanging the pump. So this is just a quick video of how the pump works. So it's, as I said, it's attached to the apex of the left ventricle. And you would see the inside of the pump in a second. And that's the outflow cannula going in. And the technology between the 2 and the Heartmate 3, which is the next pump that we are going to implant, is completely different. But this just shows how the inner workings of the pump. And this is what we actually see when we put these patients on the CT scanners and try to understand. And there's a lot of information here. I wanted to kind of go through the basics of it. So if you see here, for example, that's a cross-sectional view of the left atrium, and that's the left ventricle, and that's the mitral valve. We are not concerned about the right side of the heart, which is why the contrast is not timed for that. This is a dynamic CT imaging, meaning the images are acquired at every single cardiac phase, and we are kind of seeing them as a dynamic movie. And what you see here is that inflow cannula, this cannula that I was talking about, is the end of that inflow cannula. What you notice here is the orientation of the inflow cannula to the mitral valve. So basically, you have to get the blood into the pump, but you can see the orientation of the pump to the valve. So these are certain things. So when we do imaging, we understand anatomy, we understand the moving structures like this dynamicity of the relationship to the valve, but also what we don't see today, which our MR imaging can give, is the flow information of what happens to the flow vortices in this chamber because of this malalignment. Currently, the surgeons, with their limited direct vision into the LV, they can control to a certain things, but we still have long ways to go to complement surgical procedures with both anatomical and flow-related information. So the next slide just shows how the inflow cannula is relatively in the same position in both systole and in diastole in the two phases of the heart. And this is one of our advanced image rendering technique, which Dr. Juan Granada has showed a little bit earlier. See how we can take the CT data set and render in a way that can link to the surgeon. And I would like to repeat the quote that Dr. Lumsden always says, if you need a radiologist to interpret, I won't be able to use that information. If you render the image so that as a surgeon, when he makes an open incision, then he can relate to this information that we have to his day-to-day working field. That's another thing we learned when we work on image processing techniques, is not to focus on good old conventional radiological way of looking at images, where how we take the perspective and show those information to the surgeons so that it kind of fits to their perspective. So that's something that we are working on a lot, to how we take this information into our image post-processing techniques. So this is the same cinematic rendering of the CT image, showing the relationship of the pump and the inflow cannula, and also the cannula that's attaching to the ascending aorta, and also the coronary graft rings that you can see. This is the same information rendered in the standard. You saw in a grayscale image. Here you're seeing in these advanced rendering techniques. In the interest of time, I'm just skipping through them. So here you see in another view of the relationship of the pump to the mitral valve, which is most important structure with respect to getting the pump. So now, okay, this is all great. We took the pump out. How can we do better the next time around? So the next thing is, how can we take a pump? This is the second pump that we are going to implant. The replacement pump. This is Heartmate 3. So how do we do it better this time in terms of planning it better virtually before the patient is in the operating room? So these are images that were generated over the weekend or last Friday, where we do a 3D image of the pump by itself, and now you have a pre-operative CT information of this patient, and this green line is actually a circle of the mitral annulus that we have mapped, and this is the pump that we just scanned. So what the robotic system that you just saw in the last slide captured a few projections of the device, and you get a 3D image of the pump. Now what we're talking about is a fused image of the patient's preoperative CT image fused with the pump. And here you can see I tried to orient the pump so we have it in line to the mitral inflow, this is just showing me how I'm virtually implanting the pump. You can see how I'm rotating in two orthogonal views while I have my crosshair at the mitral annulus. This is just the inside of how this image fusion process happens. And once you kind of get your optimal alignment, now you have the final virtually implanted image. And the other thing that's helpful for the surgeon is knowing which intercostal space. So you see the ribs here, and you see the device, which intercostal space you can use for planning, for getting access, and how much distance from the midline. These are certain information we give. And as a next step, what we are also working on is, how do we get this virtual planned information that we have into the operating room as a way of 3D goggles and showing it in the surgical field, so the surgeon doesn't have to step out of their field to kind of do the task that we are trying to head them to. So the simple real-world analogy for the students that I can think of is, everyone drives today with Google Maps. Would you ever think of a scenario where you plan all your destination information and leave your phone at home and go to your car and drive? That's not going to happen any time in the last few days. That's the world we live now. But imagine the surgery, the way surgery is currently done is, you do all the planning in the radiologist's office, and the surgeons takes all that information in their head, and when they go to the surgery, do the procedures, they're going free solo. So basically they have to remember and relate what they saw in the preoperative image to what we see in the actual surgical field. So that's the gap that we are trying to bring, is how we can use preoperative and intraoperative imaging, whether it is CT, MRI, or ultrasound, and put it in the perspective for the surgeon so they can do these procedures in a better and safer way. Thank you, Dr. Lumsden, for the opportunity.
So just so you got this concept, this pump that we've got down here is, we made a CAT scan of the pump. We make a CAT scan of you. On a workstation, we take this pump and virtually implant this. knowing that the blood comes through the mitral valve, you really want this oriented towards it. As a surgeon, you can't see inside the heart. And so we're taking these and using these planning tools to optimize the operation. And there's some intraoperative guidance tools that will help us do that. So I'm going to introduce Dr. Tom MacGillivray. Basically, he's the chief of cardiac surgery here, heads up the transplant program. To continue, basically, down in Boston, as Billy started, we stole him from Harvard and MGH, so the pillage continues at Billy, and we're very proud of that. He knows a lot more about what's going on in this operating room than I do, and he's going to come up and narrate what you're going to see. Thanks,
Great.
Tom. Yeah.
Thanks,
Take
Alan.
care.
So why is this important? I mean, these are great pictures and images and how to map this up, but why is it important? Well, to put it into perspective, heart disease is the most common cause of death in the United States. It kills more people than all forms of cancer combined. And the final common pathway of lethal heart disease is heart failure. Besides being lethal, it's very expensive. It's the most common diagnosis for hospitals like this. Patients with heart failure are, as we refer to, as frequent flyers. They're constantly being admitted. They go into the intensive care unit. Their cost is, the price of their care is extremely expensive. And it's very debilitating. These patients, heart failure is something that takes place over a period of years. During that time, the quality of life, their ability to work, their ability to do things that they like to do gets slowly chipped away until they get advanced heart failure. About 20 years ago, there was a study that if you had stage D or advanced heart failure, the likelihood that you would live 1 year was 25%. So we have all kinds of different pumps now that we can use to support the failing heart. Heart surgery, what I do on a daily basis, is possible because of a heart-lung machine, a pump that we can connect the heart to and allows us in a period of, to do open heart surgery, replace valves, do bypasses. That was a pump that was developed in the from the 1930s to the 50s. It was designed to last from minutes to hours, to support the heart from minutes to hours. In the 1960s, when heart surgery was getting ramped up, what we learned was that some hearts didn't get fixed enough to be able to come off that heart-lung machine, and they needed to be supported temporarily. Those were pumps that were designed to last for hours to days. First one that was done was in the mid-60s. It supported a woman after she had heart surgery. It was a big console outside the body, and there were tubes going into and out of the patient. Over time, those pumps got smaller, better, able to be implanted, and designed now to last for days to weeks to months to years. And so we're now able to implant pumps like this inside the body to support people with heart failure for years. So what we're going to see now is live surgery. A couple of my colleagues, Brian Bruckner and Eddie Suarez, are exchanging one of these pumps. Ponraj showed you a Heartmate 2. That's a...
They're not quite ready, Tom. They're going to come to us in a couple more minutes. Yeah.
Okay.
Yeah.
So that in the 2000, this study that I talked about compared medical therapy with one of these pumps. The Heartmate 1 is what we refer to it. That was a pump about the size of a tape recorder, maybe a. Big around a cicada coffee. Yeah, it was about it was a pulsatile pump. We have, when I was in medical school, I was taught you need to have pulsatile blood flow in order to live. That non-pulsatile blood flow, you can survive for a few hours, but you really can't survive without it. And so many of the early pumps were pulsatile pumps that did just what our heart does. It fills with blood, then it pumps it and empties the heart, fills, empty, fills, empty. These displacement pumps are problems. They're big because you need to be able to have the same volume of the heart. the displacement, you have to somehow figure out how to displace the air or something that's going to make these pumps go up and down. So there was a great interest in non-pulsatile pumps. It was first demonstrated that not only could you survive, but you could survive for a long time.
So let me
with them.
push on that. So whenever you feel the radial pulse at the moment, put your hand on your artery at your wrist and you feel your heart beating. That's the definition of being alive. Okay. Now, could you be sitting there with no pulse? Because that was the quantum leap. This is as big a leap in thinking as putting stents in the coronary arteries, okay? Because what you feel is a difference in pressure. High pressure, low pressure. That's what you're feeling. And so another bunch of crazy people thought, well, you don't really need a pulse to be alive. Making the pump a little bit easier, and you have you have no pulse. So you could all be sitting here with these pumps, and you go in, your doctor comes in, you feel your pulse, and you go, "You're there? Are you there?" And so, is there any downside of having no pulse, Tom?
Well, I think so. I mean, we're finding that when one of the things that
I think you become a neurosurgeon, to be completely honest.
Well, so Dr. Britz made a great presentation, but truth be told, without blood flow, the brain maybe can last 6 minutes. So I guess it's good while it lasts. But so that one of the things that happens with pulsatile flow is that our blood vessels, when you look at the big arteries, they pulsate. And if you look at the small arteries, that there's something that is different. The way that, the heart pumps blood. Blood is actually the workhorse. It carries, the blood we think of as the liquid, but blood is actually a very complex organ. And it carries oxygen, it carries nutrients, it carries parts of the immune system, and it's very sensitive. If you think about it, if you poke a hole in a blood vessel, all the blood would come out unless it had some mechanism to stop it. So the blood is able to recognize when it's not inside a normal blood vessel. And what it does is it goes from being a liquid to being a clot. But, obviously, if all you did was go to a clot, you would run the risk of clotting your whole body or clotting your whole arm. So it's a very carefully regulated, controlled mechanism to do that.